Hello, Medicos. Good day to all of you. So, this is Dr. BK for you, and in today's class, I will be continuing with the larynx. So, in the first part of the larynx class, I mainly discussed about the skeleton of the larynx, that is the cartilages, and then the membranes and the ligaments of the larynx. So, in today's class, we will be continuing with the larynx, and our learning objectives for today will be mainly we will be actually concentrating on the cavity of the larynx. So what are the features on the cavity of the larynx, followed by that muscles of the larynx. So the action of the various muscles of the larynx, both the extrinsic and then the intrinsic muscles, we will be discussing. Then followed by that, we will also have a short discussion on the shape of the Rima during the various what do you call actions, like whether normal or forced breathing and in high pitched sound and so on. And then we will actually enumerate the blood vessels and the lymphatics draining the larynx, and more importantly the nerve supply of the larynx. And finally we will actually conclude this session with the clinical aspects. Now first, coming to the cavity of the larynx, so here you are able to see the cavity extends from the upper border of the epiglottis to the lower border of the cricoid cartilage, and the vertebral level should be from the C3 to C6 level. Now if you look at the cavity, uh, the anterior wall is somewhat oblique and longer as compared to the posterior wall. Okay, now why? This is because the epiglottis, which is situated like an open lid. Okay, now this epiglottis, since it is actually situated like an open lid, accounts for the anterior obliquity of the anterior wall, and that is why this is longer than the posterior wall. Now this cavity of the larynx is actually guarded by the inlet of the larynx. So it is through this what happens, the air has to enter, and the inlet has one more function. It is to prevent mainly any foreign particles entering into the respiratory passage. So it is also, that is why, considered as the watchdog. The larynx itself is considered as the watchdog of the respiratory system. So even the food particles accidentally should not enter into this laryngeal cavity. Now coming to the inlet of the larynx, it is bounded anteriorly by the epiglottis. Okay, so that you're able to see the epiglottis covered by the mucous membrane, and on either sides by the airy epiglottic folds. So on either sides by the airy epiglottic folds, and behind, okay, it is actually covered by the interarytenoid fold of mucous membrane. So it is the fold which is stretching between the two arytenoid cartilages, and that fold also contains one muscle, that is the transverse arytenoid muscle. Okay, so those are the boundaries of the cavity of the larynx. So epiglottis in the front, airy epiglottis on the sides, and the interarytenoid fold of mucous membrane behind. Now if you look at the interarytenoid fold, within it, it contains two muscles. You are able to see one is the airy epiglottic muscle, and other one is the thyroepiglottic muscle. The airy epiglottic muscle is mainly responsible for actually closing the inlet of the larynx. Okay, so during the elevation of the larynx, that is the whole larynx elevates and approximates towards the epiglottis. So it helps to actually bring the two airy epiglottic folds together. So that is why its prime action is mainly responsible for closing the inlet, and the area epiglottis muscle itself is considered as the upper continuation of the oblique arytenoids. So that we will come to it in the while we discuss about the muscles of the larynx. The other muscle what you are able to see here is the thyroepiglottic muscle which you are seeing. Okay, so thyroepiglottic muscle is again what do you call as it is responsible for mainly opening the larynx, which is a very passive action. Then apart from that, in the area epiglottic fold you come across two cartilages, that is the corniculate and the cuneiform cartilages. So these two cartilages, they helps to keep this fold propped up and does not collapse, mainly during the closure of the inlet. And lateral to the area epiglottic fold, what you see is this membrane which we have already discussed in the previous class, that is the quadrate membrane. Okay, so in this fold mainly you are able to see the upper part of the quadrate membrane. Okay, and the lower border of the quadrate membrane is thickened to form the vestibular ligament. So you can see the quadrate membrane once you actually remove the airy epiglottic fold of mucous membrane from the medial side. Okay. So as I told you, during the closure of the inlet, the airy epiglottic muscle is actually approximated, and opening is actually the passive action because the gravity itself assists in opening the larynx. So whatever the elevated larynx has to come back to its original position, and that is passively assisted by the thyroepiglottis muscle. And one more thing is the inlet is lined by stratified squamous epithelium. So whereas the remaining part of the what do you call the larynx is lined by the pseudostratified ciliated columnar epithelium, which is the respiratory epithelium. But here in the inlet, the area epiglottic folds and the upper part of the posterior surface of the epiglottis is lined by this stratified squamous non-keratinized epithelium. So now from the inlet, as you go downward, you enter into the cavity of the larynx. So now you are able to see the cavity of the larynx. Of course, you are able to, here you are seeing only the anterior wall. This is actually a coronal section. It is divided into following three parts. Now the first part which you enter immediately deep to the or below the inlet of the larynx is the vestibule of the larynx. So that extends from the inlet to the vestibular folds. So that is, you have a small space between the two vestibular folds, and that is called as the Rima vestibuli. Okay, the vestibule is actually somewhat funnel shaped. Okay, so that is the vestibule, or sometimes called as the supraglottic part of the larynx. Then the next you are able to see a narrow space and also which is extending laterally. So that part is actually called as the ventricle of the larynx. So the ventricle of the larynx is actually a space which is present between the vestibular folds above and the vocal folds below, or you can represent it is actually a gap between the quadrate membrane above and the cricovocal membrane below, because these two folds, the vestibular or the vocal folds, are nothing but the thickening of the quadrate membrane, lower part of the quadrate membrane, and the vocal fold is the thickening of the upper part of the cricovocal membrane. So these two membranes, there is a space which is interrupting between these two, and that is actually called as the sinus of the larynx. Now, if you look at the sinus of the larynx, the mucosa actually what happens is it forms a diverticulum on either side, extending laterally, and that is called as the saccule of the larynx. So that is actually called as the saccule of the larynx. It extends up to the thyroid membrane. So that is the thyroid cartilage you're able to see, and that should be your thyroid membrane. This is your hyoid bone. So it extends anteriorly and above to the thyroid membrane. So that is called as the saccule of the larynx. So mainly this mucus pouch or the diverticulum, the mouth of it is opening medially into the cavity. So the mucus secretions are mainly responsible for keeping the vocal folds moist. Okay, so because the vocal folds they lack submucosa, only in the submucosa you will have this submucous glands which is lacking here. So that is why what happens is the saccule of the larynx actually the secretions of it helps to keep the mucous membrane moist. So that is why the saccule of the larynx is also called as the oil can of the larynx. Then in some lower forms, especially in primates, you can see this saccule is very long and it helps to hold the some amount of air. Okay, this pouch, what happens is the air is filled, so that what happens is in some free arm movements when it is using its upper limbs to actually what happens from to move from one tree to other. So what happens is in that case the vocal folds are actually closed, and that is the vocal folds acts as a entry valve, so respiration does not takes place. So this where happens this air filled sac where the inspired air is present then naturally accounts for it. Okay, so that is the mainly about the saccule of the larynx. So here you are able to see the ventricle or the sinus of the larynx, which is bounded above by the vestibular fold and below by the vocal fold. So if you go laterally, you will come across a saccule of the larynx as a mucus outpocketing. So next, coming to the other features, we have seen this is the vestibule and that is the sinus of the larynx. So the infraglottic part is the cavity of the larynx below the vocal folds, and it is somewhat like a truncated cone. Okay, the infraglottic part of the cavity, and it will be continuous with the rest of the respiratory tract, that is the trachea. Then the space between the two vestibular folds is actually called as the Rima vestibuli. Okay, so they are the space between the two vocal cords, and they mainly consist of the lining mucosa. And deep to the mucosa you have the vestibular ligament. Okay, so which is the upper lower thickened part of the quadrate membrane, and this lining mucosa has the mucosa has the lining epithelium, which is the ciliated columnar epithelium. So the ciliated columnar epithelium, which is the characteristic feature of the respiratory epithelium. Now, what happens is the Rima vestibuli acts as an exit valve. So if you take a deep inspiration and then if you want to hold the breath, then naturally the two what happens is the two vestibular folds they actually hold the expired air. Okay, so thereby the air cannot enter outside. So they act as an exit valve. So thereby when the air is actually cannot what you call breathe out, it builds inside. So thereby the diaphragm is in a contracted position, it goes down, and increased intra-abdominal pressure. So the intra-abdominal pressure is increased to holds one's breath. So this is mainly responsible for certain acts like your micturition, defecation, and voluntarily we do this, and sometimes even in lifting heavy objects. So the Rima vestibuli acts as an exit valve, so that the inspired air, what happens is, increases the thoracic dimensions, and thereby the intra-abdominal pressure is increased, which is required for certain acts. Next, coming to the next fold, what you are able to see here is the Rima Glottidis. So here above, this fold is the false vocal cords or the vestibular folds, but now you are able to see the vibrating one, which is purely white in color. That is your vestibular folds. So the sound which is produced, the organ of phonation, is due to the vibration of these vocal folds. So the space between the two vocal folds is actually called as the Rima Glottidis. The Rima Glottidis is actually the space between the two what do you call, the vocal folds. So when you observe carefully, there is a sudden blast of air. You're able to see that it abducts and then the air is released. So this sudden blast of air only produces the sound, and the tension and the rate of vibration of these vocal folds determines the pitch of the sound, whether it is high pitched sound or low pitched sound. So all the vowels are actually produced in the vocal folds, okay, between the vocal folds in the larynx, but whereas the consonants are actually not sounded here, okay. Then this sound, actually what happens is, has to be resonated, which is taking place in your nasal cavity, oral cavity, and it has to be articulated, okay. So that is the vocal folds, and it also acts as a entry valve, okay. So that is, you are able to see. We will discuss about the vocal folds much. So that is the larynx in action, which you are able to see here. So that is your epiglottis, the epiglottis which you are able to see here, and this is your airy epiglottic fold, and that should be your corniculate cartilages, and that should be arytenoid and interarytenoid fold you are able to see mainly during the abduction, okay. And this side, what you are able to see is the pyriform fossa, and more laterally this will be your thyroid cartilage, okay. So the Rima, mainly if you look at it, it has got two parts. The space itself, it has got two parts. It has got an intermembranous part, because this is actually the thickening of the membrane. No, the vocal ligament is a thickening of the membrane. That is a cricovocal membrane. That is why it is called as intermembranous part. And this is the vocal process of the arytenoid cartilage. So the space between the cartilaginous part is the intercartilaginous part between the vocal process. So when you take the vocal fold, it actually extends from the uh, vocal ligament to the vocal process, okay. So the Rima is actually extending from the inner aspect of the angle of the thyroid cartilage in front, and at the sides it is bounded by the vocal folds, which has got intermembranous and intercartilaginous part, okay. So it acts as an entry valve, as I told you. So what happens is, after full expiration, all the what do you call, the air is actually blown out of the lungs, then it prevents the inspiration, so to hold the inspiration for some time. So this is mainly done for certain free arm movements, especially by the pectoral muscles, that is your pectoralis major and your serratus anterior muscle. So these arm movements are performed without increasing the dimensions of your thoracic cavity, okay. And what happens is, it acts as a entry valve, as I told you. So when suddenly, what happens is, when the air is actually entering or blown out, that is also responsible for production of the sound which I told you. So with the cavity of this larynx, we will move on to the muscles of the larynx. So mainly there are two sets of muscles. One is the extrinsic muscles and other one is the intrinsic muscles. So first, we will discuss about the intrinsic muscles of the larynx. They mainly helps to move the vocal cords. Okay, the intrinsic muscles are mainly responsible for moving the vocal cords. Most of the muscles, intrinsic muscles of the larynx, they move the vocal cords. So, and apart from that, the, the other muscles, the intrinsic muscles are responsible for opening or closing the inlet. So these are the two main actions of the intrinsic muscles of the larynx. So the vocal cords actions are mainly abduction of the vocal cord or adduction of the vocal cord. Then the vocal cords are tensed or relaxed. So we will try to see which all muscles abduct, adduct, tense and relax the vocal cords. So the first muscle which we are going to see is our abductor of the vocal cord. So the main muscle which abducts the vocal cord is your posterior cricoarytenoid muscle, which you are able to see here. So it arises from the posterior surface of the lamina of the cricoid cartilage. You see two depressions in the median ridge on either side of the median ridge. So you're able to see that. So it arises from the posterior surface of the lamina of the cricoid cartilage, and then it is inserted into the posterior surface of the muscular process. So it is inserted into the muscular process. So that is the muscular process. Now it is pulled backwards because the muscle is in action. So you have the upper horizontal fibers and the lower vertical fibers. Okay, so upper horizontal and the lower vertical fibers. So origin is actually from the posterior surface of lamina of cricoid cartilage and insertion into the posterior surface of the muscular process of the arytenoid cartilages. It brings about abduction by two mechanisms. One is when you look at it, first let us try to see the abduction of the vocal cord. So you're able to see the vocal cords are abducted, and the posterior cricoarytenoid muscle, the tendon is pulling the muscular process backwards. So when it pulls, then naturally you are able to see the vocal cords are abducted. So this is brought about both by rotary movement. Mainly you are able to see here the rotary movement. The arytenoid itself is rotating around the cricoarytenoid joint. Okay, the muscular process move forwards and backwards. So this is mainly caused by the upper fibers of the posterior cricoarytenoid muscles. Okay, so the muscular process is pulled backwards and the vocal cords are actually abducted. And you know, this muscle is also called as the safety muscle of the larynx, because if this muscle is paralyzed, then the adductor muscles will actually get unopposed, and what happens is it might keep the vocal cords in adducted position. So naturally there will be difficulty in breathing. Okay, so that is why it is called as the safety muscle of the larynx. So when you look at the upper fibers, they bring about abduction by rotating the cricoarytenoid joint by pulling the muscular process backwards. There is the lower vertical fibers. What happens? They pull the whole arytenoid laterally. So the whole arytenoid will move laterally and then medially through its gliding action. Okay, so mainly it will move through the gliding action. So next, coming to the adductors of the vocal cord. So the adductors of the vocal cord, mainly you are able to see that is the lateral cricoarytenoid muscle. Okay, and it is also two other muscles which is bringing out the adduction is the transverse arytenoid and the oblique arytenoids. First, let us discuss about the lateral cricoarytenoid muscle. So it arises mainly. So here you are able to see from the inner surface of the uh, cricoid cartilage, anterior half of the cricoid cartilage, and where it is getting inserted into the anterior surface of the muscular process. So that is the muscular process. To the anterior surface, you are able to see the lateral cricoarytenoid muscle is getting inserted. To the posterior surface, we saw the posterior cricoarytenoid muscle. so to the anterior surface of the muscular process. So when this muscle acts, when it pulls, the muscular process will be brought forward and medially, and it will actually adduct the vocal cords. Okay, this is again brought about by the rotation. The same cricoarytenoid joins. While the posterior cricoarytenoid is pulling backwards, the lateral cricoarytenoid will pull the muscular process forwards. So you are able to see. So that is the adduction. This is by the action of the lateral cricoarytenoid muscle, which you are able to see here. So the muscular process is pulled forwards and medially, and the vocal cords they adduct. So while this rotary movement is performed by the lateral cricoarytenoids, there is also other two muscles which bring about the adduction of the vocal cord, and that is mainly the transverse arytenoid. So the transverse arytenoid is between the two arytenoid cartilages, okay, which extends between the two arytenoid cartilages. And one more muscle is the oblique arytenoid. So that is the transverse arytenoid which you are able to see here, which extends between the two arytenoid cartilages in the interarytenoid fold. And the oblique arytenoid is actually upward uh, continuation, sometimes it can be called. It extends from the one arytenoid cartilage to the apex of the opposite arytenoid cartilage. Oblique arytenoid, from the posterior surface of one arytenoid to the apex of the opposite arytenoid. So you are able to see that oblique arytenoid. And the transverse arytenoid is only unpaired muscle of the larynx. Now, this transverse and the oblique arytenoids, how do they actually bring about the abduction? So they mainly bring about the abduction by gliding movements. Now you are able to see the whole arytenoid cartilage itself is approximated. So that you can see in this short animation. So now we are able to see the oblique and the transverse arytenoids are acting. The whole arytenoid cartilage itself moves through the gliding movements. This we saw in the last slide, the rotary movements. This is gliding movements. And in humans, adduction is mainly or mostly brought about mainly by this gliding movements. Okay, so they adduct mainly the intercartilaginous part, whereas this is mainly for adduction of the intermembranous part, the lateral cricoarytenoid. Okay, so in case of paralysis of the posterior cricoarytenoid, the lateral arytenoids are adductors are unopposed, and naturally it will keep the vocal cords in an adducted position. So the main antagonistic of the adductors is the posterior cricoarytenoid, which is the abductor, and that is why it is called as the safety muscle of the larynx. Next, moving on to the next muscle, which you are able to see here, is the cricothyroid muscle, which is the tensor of the vocal cord, only muscle of the larynx which is present externally. Okay, it has got two parts. It has got an oblique part and a horizontal part. So it arises from the external surface of the anterior arch of the cricoid cartilage and inserts into the lower border of the lamina of the thyroid cartilage. Okay, so as I told you, it has got the two parts, external, um, it has got oblique and horizontal fibers. Now this muscle, when it contracts, it stretches the vocal cords, and that is why it is called as the tensor of vocal cords, and that is brought about by two ways. In two ways actually the tension of the vocal cord occurs. So now if you watch this carefully, yes, you are able to see the vocal cords are stretched. Okay, so the stretching of the vocal cords takes place. So there are two views by which the vocal cords can be stretched. When the horizontal fibers they contract, or you can tell when the muscle is actually acting from above, the cricoid cartilage, the arch of the cricoid cartilage will move above, and the lamina with the arytenoid will fall backwards. So the lamina with the arytenoid fall backwards, the vocal cord or the vocal ligament is stretched. That is one way by which the tension of the vocal cord occurs. The next way is which you are able to see in this animation as well as watch what this picture depicts is when the lower fibers contract, okay, or when the oblique fibers they contract, what happens is the thyroid cartilage is pulled downwards closer towards the cricoid cartilage. So again this will stretch the vocal cords and tense. So the two views are actually accepted and tension occurs by these two views. Okay, so what happens is this is the both the views which I have told you. So one is actually the cricoid has to move above and the lamina, and the arytenoid has to fall backwards stretching the vocal cords. Otherwise the cricoid is fixed and the thyroid cartilage moves downwards. So thereby again what happens, the vocal cords will be stretched. So here you are able to see the vocal ligament and the vocal process. Lateral to the vocal ligament you are able to see the vocalis muscle. Okay, so that also assists in the tensing the vocal cords. Okay, because vocalis, what happens is uh, it also helps in relaxing the vocal cord, that we will see in the next part. The next muscle which we are going to see is the relaxer of the vocal cord. So the relaxer of the vocal cord is mainly brought about by this thyroarytenoid muscle. So here you are able to see the thyroarytenoid muscle which will be assisted by the vocalis muscle. So from the inner aspect of the angle of the thyroid cartilage, and it goes to the arytenoid cartilage. Okay, so which is mainly seen passing through the airy epiglottic fold. It shortens the vocal ligament. So that is how what happens is the vocal cord is relaxed and it is assisted mainly by the vocalis muscle. So here you are able to see the vocalis muscle. The vocalis muscle, it is both considered under the tensor as well as the relaxer of the vocal cord, because it tenses the intermembranous part, vocalis muscle, and relaxes the intercartilaginous part. So that is what the segmental tension of the vocal cord determines the pitch of the sound produced. Okay, so the segmental tension, so it actually, the vocalis muscle stretches the anterior part which tenses, whereas it relaxes the posterior part, and that is the main function of the vocalis muscle. So we have discussed about the tensor, relaxor, adductor, abductor of the vocal cords. So inlet is mainly closed by the airy epiglotticus muscle and oblique arytenoid. So the oblique arytenoid is actually continuation. Okay, area epiglotticus. So the area epiglotticus is considered as the upper continuation of the oblique arytenoid muscle, which helps to close the, it approximates the area epiglottic fold. And muscle opening the inlet is your, so here you are able to see the thyroepiglottic muscle. So thyroepiglotticus muscle mainly is responsible for opening the inlet. It is the upper detached fibers of the thyroarytenoid muscle itself. Okay, and opening is again a passive action, as I told you. Next, moving on to the extrinsic muscles of the larynx. So intrinsic muscles of the larynx, we have seen they are mainly responsible for the movement of the vocal cords. Now coming to the extrinsic muscles of the larynx, so they move the larynx as a whole. Mainly they are responsible for elevating and depressing the larynx. So muscles which elevate the larynx, which you are able to see here, the palatopharyngeus, salpingopharyngeus, and the stylopharyngeus, which is attached to the posterior border of the lamina of the thyroid cartilage. So during deglutition, what happens is the larynx is elevated and approximated towards the epiglottis. Okay. The other muscles which assist in elevation is the suprahyoid muscles. So mainly the mylohyoid, which helps to elevate the floor of the oral cavity, and then the digastric muscles, the suprahyoid muscles. Whereas the infrahyoid muscles, what happens? You are able to see here the sternothyroid and the sternohyoid muscles. the sternothyroid muscle and the sternohyoid muscles. You are able to see that. So they actually stabilize the hyoid bone, and they also assist in depressing the larynx. Okay, the sternothyroid and the sternohyoid muscles, which you are able to see here. The thyrohyoid muscle. Okay, so they are the infrahyoid muscles to passively assist in depressing the larynx. So that is about the extrinsic muscles of the larynx. So now we will just try to understand few more aspects of these vocal folds. So as I told you, the vocal folds are actually purely white in color due to the absence of submucosa. So this is the vestibular or the false vocal cords you are able to see here, and below that you are able to see. And I told you it is made up of two parts. The anterior 3/5 is mainly formed by the vocal ligament, and posterior 2/5 is mainly formed by the vocal process of the arytenoid cartilages. And this whole, as a whole, the vocal ligament and the vocal process is covered by the mucous membrane. So deep to mucous membrane you have the ligament, okay, and then more laterally you have the vocalis muscle, okay, and the lining epithelium is the stratified squamous epithelium. It is not the ciliated columnar epithelium, because mainly they are abducted and adducted. What happens is the ciliated columnar epithelium might again irritate every time the vocal cord is vibrated. Okay, so that is why here it is mainly formed by stratified squamous epithelium, and also epithelium of wear and tear. Okay, so that is the, after removal of the mucous membrane, you are able to see the vocal ligament, which forms the anterior 3/5, okay, and the vocal process forming the posterior 2/5, and lateral to it what you see is the vocalis muscle. The vocalis muscle itself is the detached part of this thyroarytenoid muscle, medial detached part of the thyroarytenoid muscle. Okay, so that is the vocalis muscle, and submucosa is absent in vocal folds. Deep to the mucous membrane you don't have submucosa, so there is no submucous glands. So because of that, what happens is the laryngeal edema does not affect the, what do you call, the vocal folds. So next, coming to the shape of the Rima glottidis in various movements of the larynx. Okay, so the shape of the Rima, mainly in normal breathing, you can see the intermembranous part is triangular and the intercartilaginous part is rectangular, and the shape is called as pentagon shaped. During forced inspiration or full inspiration, what happens is the vocal cords are abducted and it becomes triangular. Okay, so abduction of both the parts takes place. In humans it is mostly a wide triangle. Okay, both the vocal cords are abducted widely. Then in high pitched sound, what happens, it is reduced to a linear chink. So both parts of the vocal cords are actually adducted. A very narrow space is present, and during whispering voice it is like a inverted funnel shape. Okay, during whispering voice it is inverted funnel shape. The, you are able to see the intermembranous part is actually adducted, intercartilaginous part is actually abducted. So this whispering voice is also the most what do you call, a damaging position to the vocal cords. So you cannot keep on whispering for a very long time. It will strain your vocal cords very easily. Coming to the nerve supply of the larynx, sensory nerve supply. The mucous membrane above the vocal folds will be supplied by the internal laryngeal nerve, which pierces the thyrohyoid membrane. Internal laryngeal. Below the vocal folds, it will be supplied by the recurrent laryngeal nerve. So the internal laryngeal nerve is actually a purely sensory nerve, whereas the recurrent laryngeal nerve is actually a mixed nerve because it contains both sensory as well as motor fibers. All the muscles of the larynx are actually supplied by the recurrent laryngeal nerve except the cricothyroid, which is actually supplied by the external laryngeal nerve. Okay, the mucous membrane of the larynx is respiratory epithelium, ciliated columnar epithelium, except at certain places. That is the area epiglottic fold and the upper surface of the epiglottis and the vocal folds. So all these are actually mainly lined by the stratified squamous non-keratinized epithelium. Coming to the blood supply, mainly superior and inferior laryngeal arteries. They supply. Superior laryngeal artery is a branch of superior thyroid artery. Above the vocal folds, it supplies the larynx. Okay, superior laryngeal artery. Below the vocal folds, the inferior laryngeal artery, you are able to see that from the inferior thyroid artery, which is a branch of the thyrocervical trunk, which gives the inferior thyroid artery, gives the inferior laryngeal artery below the vocal folds. So veins actually corresponds to the arteries. Lymphatics above the vocal folds, it is mainly drained by the pre-laryngeal nodes, which drain into the jugulodigastric nodes. Okay, so the pre-laryngeal nodes mainly they drain into jugulodigastric nodes, whereas below the vocal cords it is mainly drained by the pretracheal and paratracheal nodes. Okay, so that is why the vocal cords is also called as the watershed line. That means the lymphatics don't cross above the vocal folds. The lymphatics drain into the prelaryngeal nodes. Below the vocal cords, they drain into the pre or paratracheal nodes. So coming to the clinical aspects. So mainly what happens is if there is unilateral damage to the recurrent laryngeal nerve. So one half of the muscles of the larynx are paralyzed and you can able to see the vocal cord is in adducted paramedian position. So here you are able to see what happens. The right cord is normal, it is an abduct, but whereas this is paralyzed. So since one half is there, what happens is there won't be any difficulty in respiration, but hoarseness of voice will occur and weakness in producing the voice might actually takes place. So mainly the hoarseness of voice you can see if unilateral paralysis. So in bilateral paralysis, what happens is both the vocal cords will come to lie in a paramedian position. Okay, in that case, what happens? You won't be able to produce any noise, and there will be also difficulty in breathing, or mainly on exertion, because it will allow some amount of air, but since it cannot abduct completely, what happens is when you exert, when you run or walk fast or are ascending the steps, then you might feel exertion. This is when the bilateral damage to the recurrent laryngeal nerve takes place. The internal laryngeal nerve is involved, then naturally what happens is the mucosa is anesthetized. No sensation of mucosa. So protective cough reflex will be absent when any foreign particle enters. So when both the external laryngeal nerve and the internal laryngeal, the recurrent laryngeal nerve where takes place, both recurrent and external laryngeal nerve, all the muscles are paralyzed and you are able to see the vocal folds or the cords lie in a paramedian or a cadaveric position of the vocal cords. The Rima occurs a cadaveric position. Okay, so if the external laryngeal nerve alone is what happens is damaged, then cricothyroid is paralyzed, so the vocal cord is not tensed, so there will be a weakness of phonation. Whereas if both the nerves of both the sides are involved, then the Rima assumes a cadaveric position, so it cannot be abducted at all. And what happens is Siemens law states that in chronic paralysis or involvement of the recurrent laryngeal nerve, first the abductors are paralyzed, followed by the adductors. This is one safety mechanism because if first the what happens is the adductors are involved, then naturally what happens is it might lie in the paramedian position. This is cystic swelling of the saccule of the larynx, which is actually called as the uh, laryngocele. It might be internal or sometimes through the thyrohyoid membrane. It might also protrude externally as a swelling in the neck. Okay, this is because the inflammation of the glands lining the saccule of the larynx, that is called as laryngocele. Next, Singer's nodules. So you're able to see small nodules which are developed when you strain your vocal cord. So naturally what happens is it might get inflamed, and they are cystic nodules which are bilateral and regular in shape. They are called as Singer's nodules or teacher's nodules because they who strain their vocal cords too much. So mainly voice rest is advised with the what do you call lot of intake of lot of fluids and voice rest. In sometimes what happens is if it is not resolving, speech therapy is also recommended. Then of course carcinoma of the larynx is also common, which affects mainly your vocal cords, and it is unilateral. You can see a mass. Okay, so with this I have actually completed the larynx. Thank you very much for your patient listening, and we will meet in one more topic.